Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO! This is our second episode in a 4-part series on uterine cancer. Today, we're going to be discussing early-stage uterine cancers. Maya, what are our learning objectives for today?
Our objectives are to discuss the surgical approach to early-stage endometrial cancer, discuss the components of complete surgical staging, including rationale and current standards for lymph node assessment, explore risk stratification for risk of disease recurrence after surgery, identify groups of patients with early endometrial cancer who benefit from adjuvant therapy, and discuss options and recommendations for adjuvant therapy for these people, to describe populations for which conservative or fertility-sparing management can be considered, and discuss options for fertility-sparing disease management.
All right, let's get started. Endometrial cancer is surgically staged, and surgery is also the essence of treatment in early stage, meaning stage 1 to 2 disease. In early endometrial cancer, the standard of care is a total hysterectomy with bilateral salpingo-oophorectomy via a minimally invasive approach, if feasible. In specific histologic subtypes such as serous and undifferentiated endometrial carcinoma and carcinosarcoma, omental biopsy or an infracolic omentectomy should be included due to the high risk of microscopic omental metastases. Identifying patients who should undergo lymph node dissection via lymphadenectomy or sentinel lymph node dissection will be further discussed in this episode.
The GOG LAP2 trial established minimally invasive surgery as the standard of care for early-stage endometrial cancer. This was a randomized controlled trial of 2,600 patients with stage 1 to 2A endometrial cancer. They were randomized to open versus laparoscopic surgery in a 1-to-2 ratio. The study found a significantly increased rate of moderate to severe postoperative events in the laparotomy group, but no difference in surgical success of lymphadenectomy or overall survival between the two groups. Notably, laparoscopic staging was completed in only 74% of patients, with a 26% conversion rate, which correlated with BMI. Both groups had low risk of recurrence, and thus the study did not meet the pre-specified non-inferiority endpoint. Another international randomized controlled trial, the LACE trial, randomized patients to open versus laparoscopic hysterectomy. This trial also demonstrated no difference in survival or recurrence, but improved quality of life with a minimally invasive approach. Based on these studies, an open approach to surgery should be reserved for patients in whom minimally invasive surgery is not deemed safe or feasible.
Vaginal hysterectomy can also be considered in very specific circumstances. With this approach, we lose the ability to do a nodal assessment or to complete a thorough abdominal survey, both of which are recommended. However, several studies have reported similar survival in patients with high surgical risk who are treated with a total vaginal hysterectomy versus an abdominal approach. Thus, in patients who are poor surgical candidates, at a high risk of surgical morbidity, and have a low risk of metastasis/advanced stage disease, a TVH can be considered. Maya, there are so many questions about lymph nodes, so maybe we can tackle them one at a time. Why does knowing if lymph nodes are positive even matter?
Well, as we discussed in the previous episode, stage is an important prognostic factor in endometrial cancer and often dictates the adjuvant therapy options. Patients with clinical stage 1 to 2 disease are upstaged to stage 3 disease due to positive lymph nodes found surgically. But before we perform a lymph node assessment, it can be helpful to identify who is at risk for having lymph node metastases. Is there any data to help us answer that question?
There sure is. GOG 33 was a 1987 landmark study that gave us a lot of information about endometrial cancer pattern of disease spread and prognosis. It demonstrated that a lot of patients with clinical stage 1 disease actually have extrauterine spread, including lymph node involvement. Patients with tumor limited completely to the endometrium had a risk of lymph node metastasis of less than 3%, but this group was only about 14% of cases. 22% of patients with clinical uterus-confined disease had extrauterine spread on final pathology. Thus, the study established that surgical staging gives a much more accurate sense of disease spread and prognosis than clinical staging alone.
In 2000, Mariani et al. At the Mayo Clinic conducted a retrospective study of 328 patients who had grade 1 or 2 endometrioid histology, less than or equal to 50% myometrial invasion, and no intraoperative evidence of spread. 57% of these patients had a pelvic lymphadenectomy performed, and in 5% of those, positive lymph nodes were found. In patients who had a primary tumor less than or equal to 2 centimeters, there were 0 patients with positive lymph nodes and 0 deaths. Thus, they proposed the Mayo criteria to identify patients at low risk of nodal disease. These criteria include less than 50% myometrial invasion, tumor less than or equal to 2 centimeters, and well or moderately differentiated histology.
In 2008, the authors put their criteria to the test with a prospective study of 422 patients with endometrial cancer undergoing surgery. 33% of the endometrioid cases and 27% overall met the, quote, Mayo criteria for low-risk nodal disease. 20% of these low-risk endometrioid cases underwent a lymphadenectomy, and all had completely negative nodes. Of the 67% not meeting the low-risk criteria and undergoing lymphadenectomy, 22% had nodal metastases. This study affirmed the previously proposed Mayo criteria as a way to identify patients intraoperatively who may or may not need a lymphadenectomy. Of note, the frozen section process at Mayo Clinic is very comprehensive, and applying this in other centers may not be as reliable. It's important to think about this when deciding whether to rely on frozen section for determining risk of nodal disease. Maya, what does the data say about the benefit of lymphadenectomy? Is removing lymph nodes important for survival beyond identifying positive nodal metastases?
This is a good question and a tricky one. We know that lymph node status affects survival, but there has been considerable debate about whether lymphadenectomy itself affects survival. In the 1990s and early 2000s, several observational studies suggested that there might be a survival benefit to complete lymphadenectomy. A 2005 case series by Havrilesky et al. Also suggested that resection of bulky disease improved survival. 2 randomized trials were then performed to evaluate this question further. The CONSORT trial, published in 2008, randomized patients with pre-op clinical stage 1, excluding low-risk disease, to hysterectomy, BSO, plus-minus bilateral pelvic lymph node dissection. This study demonstrated improving staging accuracy, but no improvement in overall disease-free survival with lymphadenectomy. The Aztec trial then randomized patients with pre-op stage 1 to 2A disease to hysterectomy with or without pelvic lymphadenectomy, and then also with or without para-aortic lymphadenectomy at the discretion of the surgeon. They didn't see any difference in PFS or overall survival between patients who had or didn't have a systematic lymphadenectomy. Note that patients in Aztec who had high or intermediate risk of recurrence were then randomized to observation versus radiation, so nodal status didn't guide adjuvant therapy. We'll discuss this in further detail later in this episode. Criticisms of these studies was that there was no systematic para-aortic lymphadenectomy and no systematic approach to using the nodal disease status to guide adjuvant treatment. 2 retrospective studies, the Mayo experience with systematic para-aortic lymph node dissection and the CPAL study, have suggested a possible survival benefit in patients who received systematic para-aortic lymphadenectomy. In the CPAL study, chemotherapy also improved survival independently of lymphadenectomy. We don't have prospective data that replicates this. Additionally, there are significant downsides to systematic lymphadenectomy. Overall risk of nodal disease in all comers with endometrial cancer is about 9%, so the vast majority of patients will not have positive nodes. patients who undergo full lymphadenectomy have a much higher rate of lymphedema and lymphocyst formation, and they also have increased surgical and postoperative morbidity.
So what about sentinel lymph nodes? Is it better, worse, or the same as a full lymphadenectomy?
The advent of sentinel lymph node biopsy has really changed the discussion surrounding lymphadenectomy. We have multiple randomized controlled trials that have evaluated both safety and efficacy of sentinel lymph node mapping. In 2011, the SENTI-ENDO study evaluated patients with stage 1 to 2 endometrial cancer undergoing surgery. They had a sentinel lymph node dissection followed by systematic pelvic lymph node dissection. The sentinel lymph nodes mapped 88% of the time and mapped bilaterally in 62% of cases. 16 of the 19 patients with lymph node metastases were detected by sentinel lymph node dissection, with a false negative rate of 16%. Notably, all of the false negatives were in type 2 endometrial cancers.
The FIRES trial was published in 2017 and established the utility of sentinel lymph node mapping and biopsy. It included all patients with clinical stage 1 disease, including all grades and histologic types. Nodes mapped 86% of the time, but only 52% bilaterally. If a side did not map, a full lymphadenectomy was performed on that side. Overall, 12%, or 41 patients, had positive lymph nodes. Of these 41 patients, the sentinel lymph nodes mapped bilaterally in 36, and sentinel lymph nodes correctly picked up lymph node metastases in 35 of the 36 patients, for a false negative rate of less than 3% among patients whose nodes mapped, and it also correlated to a negative predictive value of 99.6%.
Interestingly, some of the sentinel biopsies detected nodal metastases in patients whose result was negative on full lymphadenectomy. 17% of patients with positive sentinel lymph nodes had positive sentinel lymph nodes found exclusively in regions outside of routine lymphadenectomy, with corresponding negative non-sentinel lymph nodes in conventional spaces. This was likely due to the use of ultrastaging for sentinel lymph nodes, which has better diagnostic accuracy when compared with traditional H&E, as well as unpredictable nodal spread and person-to-person variation in lymph node drainage.
In 2020, the CENTAUR trial was published. This was a prospective cohort study which investigated the use of sentinel lymph node biopsy for patients with clinical stage 1 intermediate risk and high-grade endometrial cancer. Patients with grade 2 endometrial cancer underwent sentinel lymph node biopsy followed by pelvic lymphadenectomy, and patients with high-grade endometrial cancer additionally underwent periaortic lymphadenectomy. Importantly, this study has a lot of histologic heterogeneity. The patient population was comprised of 33% serous carcinoma, 10.9% carcinosarcoma, 8% mixed histologies, and 1.9% clear cell carcinomas. Of the 27 patients with nodal metastases, sentinel lymph node mapping correctly identified 26 of them with a negative predictive value of 99%. Okay, so I heard you mention the term ultrastaging for sentinel lymph nodes. What does that entail?
Ultrastaging is a pathology technique that involves two components: serial sectioning with review of multiple H&E stained slides with or without cytokeratin IHC staining. In a group of 508 patients who underwent sentinel lymph node mapping, ultrastaging detected an additional 23 cases of micrometastases that would have been missed by conventional H&E. Ultrastaging is key because it leads to upstaging in about 5 to 15% of patients when compared to traditional H&E.
Okay, so it sounds like to me that sentinel lymph node dissection is safe, reduces complications and sequelae of systemic lymph node dissection, and is diagnostically accurate. But what do I do if my sentinel lymph nodes don't map?
Well, you have a couple of options, but unfortunately, there's no formal recommendation to guide this decision. You could either perform a systematic lymph node dissection on the side that doesn't map, or rely on the Mayo criteria to risk stratify if you think your patient will benefit from a nodal assessment. Lymph node assessment in EIN is complicated as well. Sydney, do you want to take this one?
Sure. Well, we know that a pre-op diagnosis of EIN via endometrial biopsy will be upstage to endometrial cancer in about 40% of cases. In the majority of endometrial cancer cases, we perform lymph node assessment. Because of this, some advocate for routine sentinel lymph node biopsy in cases of EIN, but this practice is still controversial at the time of this podcast publication. Until official guidance is published, providers will have to use clinical judgment to weigh the advantages, being detection of otherwise unapparent positive lymph nodes, versus disadvantages, meaning increased operative time, procedural complexity, and risk of complications of lymph node assessment in these patients. Luckily, though, we do have some established guidelines to help us decide who may be at risk of recurrence and who should receive adjuvant therapy after surgery.
It's true, and it's super important to distinguish between patients who may be cured by surgery alone versus those at risk of local and/or distant recurrence to determine which patients are the best candidates for adjuvant treatment. The basic categories for risk of disease recurrence are low, intermediate, and high risk. Due to difficulties determining which patients should be adjuvantly treated in the intermediate risk group, it was further stratified into low intermediate and high intermediate risk. We will dive into this further in a moment. The low risk group consists of low-grade disease without LVSI, which is limited to the endometrium or has less than 50% myometrial invasion. These patients are cured with surgery and do not need adjuvant therapy. In fact, patients with low-risk disease may be candidates for treatment with progestin therapy instead of hysterectomy in order to preserve fertility.
The high-risk group consists of greater than or equal to stage 3 disease, regardless of histology or grade, or serous or clear cell carcinoma, or grade 3 deeply invasive endometrioid adenocarcinoma. These patients generally always require adjuvant treatment.
The intermediate group is a bit more nuanced. This group includes grade 1 or 2 disease invading greater than 50% of the myometrium, or disease with occult cervical stromal invasion, or grade 1 to 2 disease with less than 50% myometrial invasion with LVSI. 2 trials have established sets of risk factors for recurrence, creating a high intermediate risk group. GOG 99 compared observation versus whole pelvic radiation for the intermediate risk group. In a post-hoc analysis, the study established risk factors for recurrence when combined with age, outer third myometrial invasion, grade 2 to 3 disease, and/or presence of LVSI. In their high intermediate risk group, for whom recurrence risk was higher, adjuvant radiation had a significant improvement in recurrence rate. This group includes patients who are age 70 or older with 1 risk factor, ages 50 to 69 with 2 risk factors, or less than age 50 with all 3 risk factors. We will further discuss the trial design of GOG 99 in a moment.
PORTEC 1 and 2 also identified a high intermediate risk group, known as the PORTEC criteria. A patient must have greater than or equal to 2 of the 3 following risk factors to be considered to have high intermediate risk disease: age greater than 60, greater than 50% of myometrial invasion, and/or grade 3 histology. Deciding which criteria to use, PORTEC versus GOG 99, may vary by case and by attending. But generally, if a patient meets criteria by either one of the sets, we should treat them according to their highest risk.
Okay, great. So let's say I have a patient who's matched into the high intermediate risk group where adjuvant radiation is preferred, or the high risk group where adjuvant therapy is required. What do we know about adjuvant therapy overall?
Great question, Maya. To date, no randomized control trial has demonstrated an overall survival benefit for any adjuvant therapy in the overall study population or in a pre-specified subgroup for early-stage endometrial cancer. Said another way, we don't have evidence that adjuvant therapy helps people live longer. However, what we do know is that radiation therapy reduces the risk of local recurrence. Can you remind me how we came to know that?
Sure. GOG 99 was published in 2004. It included patients with intermediate risk disease. All patients underwent a hysterectomy, BSO, and comprehensive nodal evaluation. These patients were then randomized to observation versus 50.4 gray of EBRT. The primary outcome was recurrence-free interval. The 2-year recurrence rate was 2 versus 12% in the radiotherapy versus observation group, respectively. The 4-year overall survival was not different. A post-hoc analysis was performed to identify a high intermediate risk group of patients that seemed to have more benefit with radiotherapy as previously described. 1/3 of the study patients were high intermediate risk, and importantly, they were responsible for 2/3 of the cancer-related deaths in this group. Among the patients with high intermediate risk disease by GOG criteria randomized to observation, recurrence risk at 2 years was 27%, compared to 6% in the radiation group.
PORTEC-1 had a similar question of interest, but different inclusion criteria. It was a Dutch study published in 2000. All patients had a total abdominal hysterectomy without lymph node assessment and were included if their disease was grade 1 with greater than 50% myometrial invasion, grade 2 with any invasion, or grade 3 with less than 50% myometrial invasion. Patients were randomized to 46 gray EBRT versus observation. The primary outcome was local regional recurrence. The study found that radiotherapy significantly reduced local regional recurrence from 14% in the observation group to 4% in the EBRT group. 73% of local regional recurrences were isolated to the vagina. Notably, after recurrence, survival was poorer in patients who had previously received therapy. This suggests that recurrences were easier to salvage in patients who had not been previously treated with radiotherapy. This study found the recurrence risk higher in patients aged greater than 60, greater than 50% myometrial invasion, and grade 3 histology, which established the, quote, PORTEC criteria as previously described.
PORTEC-1 was naturally followed up with PORTEC-2, published in 2010. It was a non-inferiority trial to evaluate vaginal recurrence risk after treatment with vaginal brachytherapy versus EBRT. It included 427 patients in the high intermediate risk group established by PORTEC-1 who underwent total abdominal hysterectomy without staging lymph node dissection. The study found that vaginal brachytherapy was equivalent to EBRT in terms of reducing risk of vaginal recurrence. It additionally found that EBRT does reduce the risk of pelvic recurrence from 3.8 to 0.5%, but there's additional GI toxicity with EBRT. The disease-free survival and overall survival was equivalent between the two groups. Thus, PORTEC-2 established vaginal brachytherapy as the new standard of care for adjuvant treatment of early-stage high-intermediate risk endometrial cancer.
We mentioned the Aztec trial earlier, which was a 2-phase study. In phase 1, patients with clinical stage 1 disease were randomized to observation versus systematic lymphadenectomy after HIST. In the second phase of this study, patients with high or intermediate risk of recurrence were randomized to radiation versus observation. The results of this second phase of the Aztec trial were combined with the results of another trial, EN.5, due to low recruitment in each individual study. The objective was to evaluate the impact of adjuvant radiotherapy after surgery. In these studies, physicians were allowed to administer vaginal brachytherapy in either the observation or the EBRT arm, so some patients in the observation arm did get radiation also. The takeaway from this study was that there was no benefit to post-op radiotherapy in intermediate or high-risk endometrial cancer, and pelvic radiotherapy had more side effects. There was also no differential impact on outcomes when stratifying results by lymphadenectomy status. For example, it didn't matter if you had a previous lymphadenectomy. Note that these trials had a lot of complicating pieces, namely that about 70% of patients in both arms had a full lymphadenectomy, and staging results weren't used to guide therapy, and 50% of patients in the EBRT group also got vaginal brachytherapy.
So, it seems like the majority of the evidence points to adjuvant radiotherapy decreasing local regional recurrence in patients with high intermediate risk endometrial cancer. What do we know about adjuvant chemoradiation?
GOG 249 sought to answer whether chemotherapy plus vaginal brachytherapy improves recurrence-free survival compared to EBRT in patients with high intermediate and high-risk early-stage endometrial cancer. 601 patients were randomized to vaginal brachytherapy with 3 cycles of carboplatin and paclitaxel given after the brachytherapy versus 45 to 50.4 gray EBRT. There was no evidence that vaginal brachytherapy with chemotherapy was superior to EBRT in terms of recurrence-free survival or overall survival. There were higher pelvic and periaortic recurrences in the vaginal brachytherapy/chemotherapy group, 9%, versus the EBRT group, 4%, and no differences in distant or vaginal recurrences. The patient-reported outcomes favored EBRT in terms of fatigue and neurotoxicity. Overall, this study suggested that pelvic radiotherapy should remain standard of care in patients with high-risk early-stage endometrial cancer, and addition of chemotherapy may not improve outcomes.
Magi et al. In 2006 evaluated chemotherapy versus radiotherapy in high-risk endometrial cancer. The study included patients with stage 1C grade 3, 2A to 2B grade 3, and stage 3 disease. Serous and clear cell histologies were excluded. 2/3 of the patients had stage 3 disease. Patients received cisplatin, doxorubicin, and cyclophosphamide every 28 days for 5 cycles versus 40 to 50 gray of EBRT. The overall survival and progression-free survival at 3 years were not significantly different. However, the authors stated that chemotherapy seems to prevent or delay distant relapse more than radiotherapy, and that radiotherapy seemed to prevent or delay local recurrence more than chemotherapy.
In 2018, PORTEC-3 was published. It compared adjuvant chemoradiation versus radiation alone in patients with high-risk endometrial cancer. Patients underwent hysterectomy and BSO with an optional lymph node dissection. 58% of patients in each arm underwent lymph node dissection. The primary outcome was overall survival and, quote, failure-free survival, meaning time from randomization to any relapse or death related to endometrial cancer or treatment. The 5-year overall survival was not significant between the groups, but the failure-free survival was in favor of the chemoradiation group. 76 months in the chemoradiation group versus 67 months with radiation alone. Chemoradiation had a much higher rate of grade 3 adverse events, but after 1 year, the adverse events were not different between the 2 arms. The takeaway here is that chemoradiation improves failure-free survival when compared to radiotherapy alone for patients with high-risk endometrial cancer, and that patients with stage 3 disease and serous cancers have the most benefit. Chemoradiation should not be recommended for stage 1 or 2 disease. Maya, are there any other factors to consider when deciding on adjuvant therapy?
Yeah. In July of 2023, Horoweg et al. From the PORTEC study group published an analysis of PORTEC-1 and PORTEC-2 results with the molecular classification. No local regional recurrences were observed with POLE-mutated tumors. In MMR deficient tumors, local regional recurrence-free survival was similar after EBRT, VBT, and no adjuvant therapy. In P53 mutated tumors, EBRT had a substantial benefit over VBT and over no adjuvant therapy. In the NSMP population, radiation of either type was better than observation. Based on these results, FIGO 2023 guidelines recommend consideration of de-escalation of therapy for POLE-mutated tumors. Currently, PORTEC-4A is ongoing, and it's investigating adjuvant treatment of high intermediate risk endometrial cancer, including molecular subtyping.
What do we do for patients who desire future fertility or who aren't good surgical candidates?
To consider fertility sparing or non-surgical management of endometrial cancer, certain criteria must be met. The biopsy must be consistent with grade 1 endometrioid endometrial cancer, confirmed by expert pathology, with a specimen preferably obtained via DNC. The disease must be limited to the endometrium on imaging. MRI is preferred, but ultrasound is acceptable. There must be an absence of suspicious or metastatic disease on imaging. There must not be any contraindications to medical therapy or to pregnancy. And lastly, the patient must be counseled extensively to understand that this is not the standard of care treatment. If these criteria are met, then what can we use for hormonal therapy?
The progesterone IUD is now listed in the NCCN guidelines as, quote, preferred for fertility preservation. Other options include medroxyprogesterone and megestrol. Patients should undergo endometrial evaluation with tissue sampling every 3 to 6 months. If there is persistent disease at 6 to 12 months, surgery is recommended. However, there are some patients where ongoing fertility-sparing treatment can be considered. After completion of childbearing, a hysterectomy and bilateral salpingo-oophorectomy plus/minus lymph node dissection is recommended.
On occasion, patients may inquire about ovarian conservation. This actually may be considered in premenopausal patients with stage 1 disease, normal-appearing ovaries, and no familial predisposition to cancer. Long-term follow-up data suggests that this is oncologically safe. Remember that a salpingectomy would still be recommended.
That's all we have for you today. We hope you learned something on today's episode of Ready, Set, GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways.
Endometrial cancer is surgically staged, and early endometrial cancer, which is stage 1 to 2 disease, is surgically treated, with or without adjuvant therapy. Based on results from the GOG, LAP2, and LACE trials, minimally invasive hysterectomy has been established as the standard of care for endometrial cancer due to improved quality of life, less surgical morbidity, and equivalent oncologic outcomes when compared to open surgery. Open surgery should be reserved for patients in whom a minimally invasive approach is not feasible or safe. Vaginal hysterectomy can be considered for patients at high risk of surgical morbidity and at low risk of metastasis or advanced disease.
Complete surgical staging for endometrial cancer includes hysterectomy, bilateral salpingo-oophorectomy, assessment for lymph node metastasis, and in high-risk histologies, being serous, clear cell, or carcinosarcoma, and omental biopsy or infracolic omentectomy. Assessment of lymph node status is crucial as it can be an important prognostic factor. Patients at low risk of lymph node metastasis can be predicted with the Mayo criteria. With publications of the FIRES trial and the CENTAUR trial, sentinel lymph node biopsy compared with complete pelvic and periaortic lymphadenectomy has been shown to be safe and effective, with false negative rates of 1 to 3% and reduced surgical morbidity.
Endometrial cancer is stratified as low risk, low intermediate risk, high intermediate risk, and high risk disease, based on risk of disease recurrence postoperatively. Low-risk disease includes patients with low-grade disease limited to less than 50% myoinvasion and no LVSI. Intermediate risk is a heterogeneous group split into low and high intermediate risk based on GOG 99 and PORTEC 1 criteria. Established risk factors are age, grade, depth of invasion, and in GOG, LVSI. If meeting high intermediate risk criteria by either schema, patients should be categorized as high intermediate risk. High risk disease includes greater than or equal to stage 3 disease, serous, clear cell, or grade 3 deeply invasive endometrioid adenocarcinoma.
Adjuvant therapy for early stage endometrial cancer has not shown an overall survival benefit in any randomized controlled trial. Any adjuvant therapy is given in an effort to decrease recurrence risk. Radiation therapy reduces the risk of local recurrence and is recommended for high intermediate risk disease, with vaginal brachytherapy preferred over EBRT. High-risk disease requires adjuvant therapy, and in high-risk histology groups, chemotherapy is often given to reduce the risk of distant recurrence. With the new FIGO 2023 guidelines, molecular subtypes of polymutated and P53 abnormal can also be used to help guide adjuvant therapy decisions.
To meet criteria for fertility-sparing management, patients must have endometrioid disease, grade 1 and stage 1A disease. They should also have imaging, which confirms disease is limited to the endometrium. Options include ovarian preservation, hormonal management, with progesterone IUD recently being upgraded to the preferred method. If undergoing hormonal treatment, surveillance with endometrial biopsy should be performed every 3 to 6 months. This has been another episode of Ready, Set, GYO, your source for all things Gyn-Onc.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com. the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at Ready, Set, GYO.
To support us and our production of future episodes, check out our Patreon at Ready, Set, GYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editor is Brogan Brown.
Our media and website manager is Sky Jacobson. We'd like to thank Dr. Summer Wallace, faculty at the University of Wisconsin, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.